Good morning, everybody. Welcome to another online Zoom webinar, a COVID-19 webinar series presented and brought to you by the National Institute for Occupational Health, a division of the National Health Laboratory Services, the NHLS, and sister division of the NICD, the National Institute for Communicable Diseases. I welcome you to our webinar with the topic today, COVID-19 and travel medicine. We have a distinguished list of guests that will be dealing with the different topics, but without a further delay and ado, I would like to briefly hand you over to Dr. Nompumelelo Ndaba, who is currently leading our occupational medicine section here at the NIH for a welcome. That's a welcome for all of you to the NIH COVID-19 webinar. Over to you, Mpume. So whilst we're waiting for Mpume, oh, okay, you connected?
Yes, I'm connected. Good morning and welcome to everyone. Welcome to this webinar today offered by the National Institute for Occupational Health. The webinar today is on COVID-19 and travel medicine. So the National Institute for Occupational Health is a division for National Health Laboratory Service. We have provided information and support to workplaces and employees in different workplaces and mainly occupational health and safety fraternity and other key stakeholders on COVID-19 and the workplace. So the focus for these webinars has been mainly on workplaces, be it physical workplaces, virtual workplaces, and actually those who are working from home. However, there have been concerns that have been raised around traveling workers, including people for people traveling for business purposes and whose inherent work involves traveling and working through the ports of entry within the African continent and also internationally. So there have been recent developments with regards to, from the South African context, ports opening, airports opening, and so forth. So there have been issues around, COVID-19 passport. How do we protect ourselves as workers as we engage with these areas, involving the different areas we use when we travel, but also the tourism areas where we might have to reside in. As a special flag for today's presentation, I would like to remind all of us that we are approaching Easter holiday and the long weekend in South Africa. So most of the workers will be traveling and engaging with some of these different areas. So it's very important when we take into consideration how do we protect ourselves as we engage with these areas. On that note, I'd like to specifically welcome our special presenters today who are going to provide expertise on these various areas, and welcome you to the NIH. Thank you.
Thank you very much. That's Dr. Nompumelelo Ndaba, the colleague from the occupational medicine section here at the NIOH. I thank you very much for that welcome of our attendees today of this travel medicine webinar. And our guests today, we have lined up as our first presenter, Dr. Albie de Vrij, who's going to deal with business travel during the COVID-19 pandemic. What's the way forward, Corvadis? And the second presenter is Dr. Lisejo, I hope I'm pronouncing that properly, it's not Desejo, Bogatso, who's going to deal with COVID-19 aviation industry preparedness, opening airports and borders for international travel. Our third presenter is Mr. Tsifiwa Tsivengwa, who's going to deal with the travel and tourism protocols. The fourth presenter is Ms. Pam Masilela, who's going to deal with traveling through ports of entry, and that is particularly dealing with port health issues, given that she is with the Port Health Services of the Department of Health. So without much further delay, I'm going to ask Dr. de Vrij just to get his presentation prepared and to check his audio. And by way of introduction, Dr. Albert de Vrij, albeit commonly and affectionately known, has obtained a medical degree from the University of Pretoria in 1983 and followed by multiple diplomas, not just in primary emergency care and anesthesiology from the South African College of Medicine, also a diploma in travel medicine from the University of Glasgow, and a certificate in travel health from the International Society of Travel Medicine. He's a senior honorary lecturer at the School of Public Health, Faculty of Health Sciences at Wits University, and holds a number of other important contributions at that particular institution, including the James Cook University in Townsville, Australia. He's a member of the World Health Organization expert roster on travel health based in Geneva, Switzerland. And he's the founding member of Travel Doctor Corporate, director of the Travel Doctor in South Africa, and a medical director of the International Health Management Consultants, also based in Geneva, Switzerland. And is currently involved in providing comprehensive travel risk management to several multinational companies, taking care of approximately 5,500 corporate travels and national employees globally. He's a member of the South African Society of Travel Medicine, in fact, a founding and an executive committee member. And then finally, International Society of Travel Medicine, also a Travel for Work Council member there. And with that introduction, that's much more I can share. I will end with that summary of Dr. de Vrij's bio sketch. Good day, Dr. de Vrij. Is your audio okay? I see you're still muted. And if you could please, good morning. Thank you for joining us and for taking the time. I know in your very busy schedule to share with us your knowledge, experience, and insights with our attendees, our stakeholder attendees on this webinar. If you could please just share your presentation slides. Your audio is perfect. In the meantime, a bit of admin quickly for those attendees who are on board. Thank you. I can see your video. You are required to type your questions for our presenters in the Q&A box. Please, all other general admin and other aspects in the chat box. And our panelists and presenters, when they are not presenting, will be answering your questions in the Q&A box. So please do that. The hand raising facility is not activated, given that when we have large numbers of people in our webinars, it is just difficult to manage that. With those few admin announcements, I immediately hand you over to Dr. de Vrij. Thank you, Dr. de Vrij.
Yeah, good morning, Ashraf. Thank you very much. And of course, because I'm on a new computer, it now needs to be granted access to Zoom. Okay, hang on. Click to unlock. Just a sec. And maybe we can do that now. Yes. Okay. Zoom's got it. Are you there?
Yes, I am.
Okay. Now let's see if it'll allow me to screen now to that one. Share. You got that?
Yes,
I think so.
I can see the presentation. If you could maximize it, it'll be perfect. Please proceed. Okay. Thank you.
Perfect. Right. Thank you very much. I'm not going to send you a CV again because you shouldn't read all of it. So we started off by saying that we're going to talk about pandemic travel, and I subtitled it with Quo Vadis, which means where are you going? But I think that was in the good old days of glamorous Hollywood in the 1950s, when travel for work was glamorous. And the Romans and the Egyptians fought it out, etc. But now we're more in an asterisk sort of mode of Quo modo vadis, which is how do we get there? How do we travel? Because in 2021, it's become a whole lot more difficult. So we've got to start off by not forgetting the very basics. So if we look at a cohort of people who travel for work, we know that 50% of people who travel for work are older than 40 years, and 50% of them have got pre-existing disease, obesity, hypertension, type 2 diabetes in particular, coronary artery disease, etc., etc., etc. And as occupational and travel health practitioners, most of you would share my frustration in trying to convince companies that people with high risk should not be sent to work offshore, particularly in places with limited medical facilities. And that most of the time our calls go unheeded in saying so. COVID-19 severity risk is said to increase independently and steadily with age. We can't do too much about that, but we've already said 50% of people who work abroad are older than 40. They're in managerial positions. They've got years of experience, and that's why they get the jobs. And the severity risk for COVID gets higher in persons regardless of age if they've got underlying medical conditions. So the comorbidities listed by level of evidence in putting you at risk of developing severe COVID is, in the first place, there's very strong evidence that serious heart conditions, coronary artery disease, cardiac failure, cardiomyopathies, pulmonary hypertension put you at serious risk for ending up in hospital or even dying from COVID, as does obesity, a BMI of more than 30, smoking, COPD, type 2 diabetes, cancer, chronic kidney disease, etc. And if we look very carefully, then we'll see that really that we're talking about almost the same conditions. So what was important previously, don't send people with a high list of pre-existing medical conditions, especially uncontrolled medical conditions. Don't let them travel to high-risk areas. Don't let them travel to areas where it's expensive to get sick. It doesn't necessarily have to be a place with poor medical facilities. It can also be a place with expensive medical facilities, such as the Americas, Canada, Japan, etc. Now, on top of that, we've got the problem that they're at high risk of developing severe COVID. And so it puts even more emphasis on that. So pre-deployment screening for comorbid disease is life-saving. I deal with some insurance companies, and we get phone calls every other day from people panicking because a 62 or a 63-year-old has just been diagnosed with COVID. The most recent one most recent two we had was Mozambique and Madagascar, and they must be medevaced immediately. They're not necessarily sick already, but people are concerned that they are going to become severely ill because they've got comorbid disease. The answer really is that they shouldn't have been there in the first place. And I know that that's difficult because sometimes people are considered to be essential workers. So if we move past the comorbid disease or the pre-existing medical conditions, then we need to educate our travelers before they go. We always need to do this in travel medicine. So they need to be educated about all travel health risks. Remember the old boring ones: food and waterborne disease, vector-borne disease, etc. Vector-borne disease, malaria has not gone away. We'll talk more about that. Non-vaccine preventable disease, vaccine preventable disease, and then, of course, COVID. Now, I'm listing it under vaccine preventable disease, but we all know that that's a serious problem at this point in time, in particular in our country, many other countries as well, but that the vaccine is not really accessible to the vast majority of the people in this country. And that's something we'll talk about a little bit more as well. And then, of course, just to make things exciting, just as we were starting, I got a WhatsApp call from one of my paramedics in Guinea in West Africa. They're about 100 kilometers from the latest outbreak of Ebola, and they've now got 2 local workers that have presented with temperatures of 39.5 and 39.8 degrees Celsius. The one is in the camp with them and has got a positive malaria antigen test. The other one is in a nearby hospital, and they're still awaiting the test. But of course, when you limit it to an antigen test, you're always concerned if there's Ebola in the area, is this just malaria? And we know that Ebola has not really gone away from the DRC either. So in the background of COVID, we have to deal with all the other usual suspects in the areas where our people work. I have to emphasize malaria. Malaria still kills. So in March last year, we repatriated a group of about 30 employees working for a mining construction company in the Copperbelt in Zambia. It was just at the start of quarantine. It was just when it was possible to bring people back on so-called repatriation flights. The guys spent a week in quarantine. They had an exit medical. They all went home happily. And a week later, one of them, a 54-year-old gentleman, died in casualty because he'd been sick for 5 days. They'd actually seen his general practitioner, who said, well, you've had a PCR screen for COVID to get you out of quarantine. You've got a bit of a sore throat. this can't possibly be malaria, even if you're coming out of Zambia, did not test him. And when the wife went to a pharmacy, got a rapid antigen test, tested him, and he was positive, phoned the GP, said, oh, bring him back to hospital. We will provide him with tablets for his malaria. She went home, picked him up, took him to casualty, and he arrested in casualty and could not be resuscitated. A couple of months later, 40-year-old expatriate from Nigeria was quarantined for 2 weeks in Nigeria before he was allowed to fly out, was quarantined for another 2 weeks in South Africa, and ended up in a little town on the south coast on the Garden Route, where he was hospitalized when he developed a fever for so-called septicemia. They did actually look for malaria, but it took a considerable amount of time and the involvement of the NICD to finally diagnose that he had Plasmodium ovale. Obviously, the first gentleman had Plasmodium falciparum that cost his life. This guy was lucky enough that the ovale was found and that he was treated for malaria. So malaria is around, it's alive, it's well. And a reminder to everybody, Mpuyo was saying just now, we're heading into the Easter weekend. The Easter weekend is always the peak time of the year when we see people dying from malaria. Every year, South Africans go to Mozambique on holiday, maybe not so much this year, but people are still working in Mozambique. And this is at the end of the rainy season is a high risk for malaria. So do not tell anybody that he's got COVID if he hasn't had a malaria smear. And remember that malaria also travels in taxis. And there's a couple of cases from the NICD communique in January explaining malaria cases occurring in Johannesburg and surrounds in the greater Gauteng area without having traveled. So the old rules stay: don't get bitten, seek early diagnosis and treatment, and take the pill. On the diagnosis, we recently dealt with a traveler. He's an IT specialist. He went to Lubumbashi in the Congo. He got sick. He got extremely tired. He was short of breath. He had a fever. And without testing, he went to a pharmacy and bought Fansidar, took the Fansidar, wasn't really feeling better, flew back down to Cape Town and was hospitalized with COVID, confirmed COVID. And now we know that there's an outbreak of COVID in that particular company in Lubumbashi, where they cannot do a PCR and everybody gets tested with antibody tests only. And then, of course, the last one for avoiding malaria is to take your prophylaxis, take the pill. But just a reminder that every fever is malaria until proven otherwise, no matter how much you're thinking and no matter how much COVID is in the forefront of our thoughts. When we get to the vaccine side of pre-travel preparation, we have to update the EPI vaccines just as always. People have not traveled for more than a year, and people forget about the vaccines. Everybody is so taken up with the idea that they need a PCR to fly somewhere that they don't actually pay any attention to their vaccines. Obviously, if they're going to a yellow fever affected area, they will still need the yellow fever vaccine. They might have lost their cards. That needs to be looked after. We need to look after their travel vaccines. And the photo on the right-hand side is just a reminder, again, a WhatsApp from Windhoek last night. Concerned colleague, this gentleman was visiting, so it's not really a travel for work, but he was visiting family in the Karoo. He was attacked by a rabid jackal. He was given a tetanus vaccine by the local general practitioner. He was given some other unknown vaccine that was called a rabies vaccine, and he was then sent back to Windhoek. That's clearly a category 3 bite. It was actually bleeding at the time. And this guy had not had pre-exposure rabies vaccine. They're now desperately looking for rabies immune globulin, because with a category 3 bite, no previous vaccination, he needs to get his rabies immune globulin. And rabies immune globulin is not available in Namibia at all. And rabies immune globulin is extremely hard to come by in South Africa right now at this point in time. We know that we've got imported equine-based immune globulin from India. But I'm stressing this story because it's real, it's now, and it stresses the importance of pre-exposure rabies vaccine. Always in Africa, it is difficult to find post-exposure treatment. And now it's even more so because it's much more difficult to fly somebody across borders at the drop of a hat. We all know that we need to start post-exposure treatment as soon as possible, and preferably within 24 to 48 hours from a bite taking place. Okay, so every vaccine that we give prevents a possible difficult Medivac. Medivac out of Africa is always difficult. Medivac in the time of COVID is even more difficult because of travel restrictions imposed by countries, by departments of health, by port health authorities, by the reluctance of countries to accept people with a fever. And so now more than ever, it's important to make sure that your traveler does not get malaria, which is a fever, and does not get another vaccine preventable disease that causes a fever. That brings us, I've mentioned Medivac, and that then brings us to travel insurance. It is essential to have travel insurance always, but it's equally important always to check the terms and conditions, and even more so now with COVID, because a lot of travel insurance will cover COVID not at all, or will cover a person for treatment for COVID where he is, but will not necessarily cover the Medivac associated to COVID. So if somebody becomes hospitalized and actually needs ventilation and or even more dramatically something like ECMO that is definitely not available in most countries north of the Limpopo, then that person needs to be Medivac. And if there's no Medivac insurance in place, this poses a major problem and puts a huge financial burden on the company. Okay, so to summarize, pre-existing medical conditions, education, malaria, vaccine preventable disease, and travel insurance all needs to be looked at in the context of traveling during the pandemic. Country entry requirements. Okay, so this is a dog's breakfast. There's no other way to put it. It changes every day. It is described as fluid when people try to be polite about it. It is often nonsensical. It is very often politically motivated and driven by politicians, not doctors. So we come across regulations that just do not make any sense whatsoever, but there's nothing we can do about it. We have to stick to them. The problem is to know what the requirement on any particular day is. If you're dealing with travelers, let's say a company that goes to a specific destination on a regular basis, one finds the ropes and then you can stick to that. But if you're dealing with individual travelers that are traveling to many places, and in particular, if they're transiting through other destinations, it can become a full-time job just to try and work out what it is. Check the official country websites. Do not pay any attention to what is said on Facebook and Instagram and what have you. That's very often wrong. Check airline websites. Very often airlines, because they get fined when they take people into countries where they're not supposed to be, and sometimes have to fly them back, the airlines are quite meticulous at trying to stay abreast of country entry requirements. And remember that the requirement for doing a PCR, because that's the bane of our lives, the requirement for doing a PCR may be dictated by the country. Most often there's something like 160 countries requiring a negative PCR certificate before they'll let somebody in. But sometimes the country is okay with not having a PCR, but the airline requires a PCR to be done. So it's very useful to check the airline website. If you've got somebody in country, it's sometimes also useful to check that. Beware of telephonic embassy advice. Telephonic medical advice from an embassy has never been reliable. And it's also not reliable when it comes to COVID. Very often the clerk that answers it knows a lot more about visas, but doesn't know anything about medicine, and we get confusing messages. Right. So if we look into the future, then we're dealing with a double future. And that's in terms of screening for current infection. That's PCRs, antigens, antibodies, and then vaccination against SARS-CoV-2. So screening for current infection is done. The gold standard for this is the PCR, or a so-called NAT test. That's how it works in practice. But the question is whether it really is the gold standard. I would believe that most of you are familiar with this graph, which is very useful. And I'd like to quickly talk through it. If we look at the black line down the middle, then that indicates when somebody becomes symptomatic if they are infected with the SARS-CoV-2 virus. For a couple of days before that, while they're still asymptomatic, the PCR may start becoming positive. That's the blue line at the top, the blue curve, okay? And the blue curve, you will see, remains positive on this graph for up to 6 weeks after the person has become symptomatic. The PCR can remain positive, and I've personally seen a guy that was sick with COVID in ICU in Panama in April last year. He eventually repatriated home in June, and his PCR was still positive, was not a new infection, was his original infection, but he still had little bits of virus floating around that are not infective, but he had a positive PCR, and we found that out when we tried to release him from quarantine. So the point about the graph is that it all circles around the onset of symptoms. So we can guess that a PCR may become positive 2 or 3 days before symptom onset, when we also know people are most infective, and it can remain positive for a long time afterwards. The purple and green lines respectively indicate IgG and IgM, that's your antibodies. They're pretty useless in detecting a current infection because they only become positive in the 2nd week of disease. And I will show you another slide to show you where the antigens become positive and become negative again. The point about this whole graph is that it refers to people who are symptomatic. It refers to when symptom onset happens. By far, the majority of people who present to travel are not symptomatic. They simply have a test because they have to have a test because the airline or the country they're going to said so. And so it makes it a lot more difficult to determine where they are on this graph if you end up with a positive PCR. So this one, it's not a very good image because it was superimposed, but Prabhardas from Lancet kindly provided the purple line there where you can see that's the range of where the antigen would become positive and become negative again. And you can see that it's a much later onset. It's much earlier before symptoms arise, and it also disappears a lot quicker and may be positive at the same time that antibodies are positive. Of course, antibodies don't help us because antibodies is your immune response to COVID, and the IgM is the early response and IgG is a later one. So that's nice to know you had it if your IgG is positive, but if it's negative, it doesn't mean that you didn't have it. So the problem with antigen testing that has been required recently by some airlines and also some countries is that they're much lower in sensitivity. So they will detect COVID much later than a PCR for shorter periods. It's best positive, your best chance of finding it positive would be in the week post-infection in a patient that is symptomatic. In asymptomatic infection, it's very hard to tell the viral loads, and it's also very hard to tell how long after infection it may remain positive, and there are a whole lot of false negatives as well as false positives. So antigen testing, even if it's required by some countries, is really not the way to go, but it may be imposed on us that it's asked for. So travelers, I've already said, are almost invariably asymptomatic, so your antigen testing is really a bit iffy. PCRs is false negative in 30% of actual cases in ill persons. That's generally acknowledged. The problem is that false positives is a reality, but it's sort of swept under the table and ignored by mainstream clinicians who work with patients, because the concern there is the person that is desperately ill in hospital has got negative blood cultures, has got negative sputums, etc., for other infective agents, and we think it's COVID, but we can't find the reason for that. So it's not really of major interest to mainstream medical academia to look at the false positives. But there's no doubt that there are false positives for a whole variety of reasons. It may be technique, it may be contamination, it may be a whole host of other things. It may just be a bad test. The problem with it in travel for work is that it causes missed flights and meetings, and all of that costs time and costs money, canceling tickets, canceling hotel arrangements, postponing meetings. It can also lead to unnecessary quarantining. I've dealt with more than a dozen travelers into Northern Africa, in particular, Sub-Saharan Africa, countries like Central African Republic, Chad, Benin, where they arrive with a negative PCR from their home countries, and they arrive and they get tested with, we're not always sure whether it's a PCR or an antigen test, and they test positive and they end up in quarantine. If they're lucky, they end up in a reasonable hotel, quarantine hotel, and if they're unlucky, they end up in a local government hospital. where they may be exposed to malaria, to tuberculosis, and a whole host of other diseases, food and waterborne diseases as well. So it's really a bad situation to end up in, and we try and avoid that. This is just some of our own statistics that shows our PCR testing on travelers from June last year up to 15th of March now. You can almost ignore the first bit because that's mostly what we did in quarantine, but you can see in purple is the number of tests we did, and the little red dots show us what percentage of our travelers that we tested were positive. Ignore the peak in August of 7.5%. You can see it was a relatively small number. We tested approximately 60 construction workers moving out to West Africa. They were all quarantined before. We tested all of them. There were 5 of them positive, of which we retested and thoroughly looked at 4 of them and allowed the 4 of them to travel, because they'd either been infected previously but were no longer infective to others, or it might have just been one of those false positive tests. If we look at the second, from October onwards, you can see that we tested a whole lot of people. There was a whole lot of movement, especially around January. But the thing that I would like to emphasize is that we can see the peak in December there of 3.5% of pre-travel PCRs being positive. That more or less coincides with our peak in the country, our second wave. But the other one that I want to point out, and we'll publish this at some stage, is that there's a very low positivity rate actually overall in travelers. Travelers are a separate cohort. It's not the same as testing the general population. People are often more careful. They're cautious when they know they're going to travel. So the whole hoo-ha about travel is more dangerous than going to the mall, I think is totally out of context, and we need to address that. Okay, so there you can see our quarantine PCRs. We did 222 of them. In the time of quarantine, 1.4% positive. So again, incoming travelers, but we tested and quarantined a hell of a lot of people to prevent 1.4% of them perhaps spreading the virus that was already well established here. And then on our pre-flight PCRs, you can see we're sitting at 1.6%. I haven't put the article in here, but the European CDC published very, very similar figures that approximately 1% of people traveling in Europe test positive on PCRs. So we have to ask ourselves, how valuable is this in curbing the spread of COVID, of SARS-CoV-2, in a time when SARS-CoV-2 is well established all around the world? And what are the economic impacts of that and the impacts on people's livelihoods, which is what we're all interested in. Right. Vaccination against SARS-CoV-2. This was from Al Jazeera just a day or two ago. What role could vaccine passports play in the pandemic? Now, if you go and look at the official WHO position papers, then the WHO will tell you that there should be no travel restrictions, that no country should require PCRs or screening of any form of travelers, and that there should not be a vaccine requirement. That's what the WHO says. We know that in practice, this is not what's happening. It's not what happened with travel restrictions. It's not what's happening with requirements for screening. And no matter what the WHO says, countries and airlines will require vaccination. So if we move on, that's an interesting one. Let's see where we are. Okay. The WHO also says that should COVID vaccination, proof of COVID vaccination be required, then it must be entered on the International Certificate of Vaccination or Prophylaxis, generally known as and used for yellow fever, so the yellow card. And I think this is a time when we're all going to have to start moving away from talking about the yellow card and associating it with yellow fever as a required vaccine for travel only, because the WHO, in as much as they say vaccines should not be required of travelers, they already say, but if it is, it must go on here. So this is just an example card of what it should look like. So you could get your COVID vaccine and you will get a little piece of paper that looks like this, okay? That's not going to be accepted at any international border post as proof that you've been vaccinated, because it would be very, very easy to duplicate this and say, I've been vaccinated. So the WHO has said that this needs to go on the yellow fever card or the International Certificate of Vaccination or Prophylaxis. However, the WHO will probably have to change the card. Where I drew the red line there, it says the patient whose signature follows, has on the date indicated been vaccinated or received prophylaxis against. And then obviously, as in the previous card, you can write in their yellow fever. But if we're now going to put yellow fever on there, as well as whatever COVID vaccine is given, and remember that, strictly speaking, people who travel from countries where polio is still endemic, such as Afghanistan and Pakistan, they should also show proof of vaccination against polio before they leave those countries, and that should also be entered on this part of the certificate. So the WHO is going to have to do a little bit of work around this. We should start thinking about how we're going to do it, because no, that's not where I want to go. I want to go back there. If this is not going to be acceptable for international travel, and it's got to go onto the yellow fever card, if I did not give the COVID vaccine, this particular COVID vaccine, in my travel clinic where I've got a record, how am I going to know that the person presenting this card has indeed been vaccinated and that this is not already a fraudulent card? It means that travel clinics, who are the only clinics in the country that can legally obtain international certificates of vaccination and prophylaxis for yellow fever purposes, it means that anybody who travels will have to go to a travel clinic with solid proof that he'd been vaccinated and get that transposed onto the yellow fever certificate, or not the yellow fever, you see the yellow card, the International Certificate of Vaccination and Prophylaxis. So people in the powers that be need to start thinking, how are we going to do this? Because you can see that even on this legal vaccine card, the EVDS vaccination number and the proof of vaccination code is two totally different numbers. And in my understanding, the person that got this card, who's a doctor, said he only wrote down the proof of vaccination code. That does not normally come onto the card. I'm not sure about that, but this is our dilemma. How are we going to know that somebody has indeed been vaccinated or not? We're going to have to think about that. Then there's something called immunity passports, and you can read about it all over the place, especially digital or cell phone-based immunity passports. And again, it's extremely controversial. The WHO and a whole bunch of bioethicists says, no, immunity passports are something of the devil because you're discriminating against people that cannot have an immunity passport. An immunity passport may be because you've been vaccinated, but it could also be because you've got proof of antibodies because of natural infection, or even because you've got a negative PCR for now. The real world is saying, yes, we want our lives and our work back. And you can see the picture on the top right there. Israel, that has vaccinated 109% of their population, are already using so-called digital immunity passports just for people to gain access to a gym or to go to a restaurant or to go to a movie theater. So it is happening out there. And the European Union is also discussing amongst themselves how they can use digital passports to help with border crossing. So it is in fact happening, no matter who says what. What about being a South African? Well, you all know that we've now got the so-called zombie virus, the new variant that is more dangerous, more infective, and arguably killing or not killing more people than the original variant, and that the vaccines that we have do not work that effective against it. This poses a major problem for South Africans, because already we know that there are countries that have opened up for tourism and say everybody's welcome, and they don't have to quarantine except South Africans. So I hope we've got some scientists out there listening and working very hard on bringing the world to a point of reality, to realize that there are many variants out there that are not necessarily being diagnosed because they're not looking for them. Remember, Tolkien said, you see only what you look for. And that we can't be discriminated against just because we were unlucky enough to have a clever professor that picked up our new variant, and that we're still struggling to see what drove our second wave, not necessarily the new variant, because then how come Europe without our variant is having a third wave and America had a third wave? So that is posing a problem for us also in terms of our work, in being able to work. So we're already being discriminated against and we really need to work hard to change that. One of the ways that we may eventually get away with it is if we have an effective vaccine, which we've been hoping and praying for a year, that also clearly works against the new South African variant. But that means that we also have to have the vaccine. And so this is, in a way, a call to arms. All of us involved in occupational health needs to advocate on behalf of those who travel for work. We can't say to a 35-year-old, otherwise fit and healthy marathon running geologist, you can't go and work abroad because you haven't been vaccinated. And because you don't have comorbid disease and you're not old enough, you're going to have to wait for your vaccine for another 2 years. People in this country are desperate for work, and many people cannot get work in this country, and they are dependent on their livelihood and putting bread on the table to get to work abroad. And very often in developing countries with a limited medical resources, but who will also say, in order to protect their own public health, they are not going to want South Africans there unless they can show that they've been vaccinated. So we also have to advocate to get the vaccine and get it sooner, not later. We have to question unscientific, unreasonable, obstructive regulations. We all saw many of them during our ordinary lockdowns, but they're still out there in terms of travel. One of the major airlines came up a little while ago, I won't mention names, with over and above a negative PCR because of the South African variant. You also have to have an antigen test done 4 hours before you board. We were involved with that. It's almost physically impossible to do antigen testing on 300 passengers getting on a 777 in the 4 hours before boarding. They've now changed that regulation. I'm not going to go into the detail about that, but they've actually come to their senses and made it a lot more practical, because what we say is necessary also needs to be it needs to be practical. One needs to be able to apply it in practice. It can't just be a theory. And then we have to vaccinate. We have to vaccinate ourselves as healthcare workers, and we need to vaccinate our travelers. And we need to keep on talking to people who come up with weird and wonderful ideas about why vaccination is not a good idea. We must have vaccines for travel for work, and we need to have them now. We can't wait for 2 years to start vaccinating people who travel for work. I hope I haven't overstepped my time, and that is the end. Thank you very much, Ashraf.
Thank you, Dr. De Vrij. If you could just unshare your presentation. Thank you very much for that. The extra few minutes was worth it. Don't worry, we will make it up. So our next presenter is Dr. Bogatso. I hope I'm pronouncing your first name properly. It's Lisego. Some names I think it's D. So a senior aviation manager at the South African Aviation Authority. Dr. Bogatso, if you could share your slides and check your audio. Dr. Bogatso is going to deal with COVID-19 aviation industry preparedness, the opening of airports and borders for international travel. And whilst the slides are being shared by way of introduction, a very short bio sketch on Dr. Bogatso. As I mentioned, is a senior aviation manager at the South African Aviation Authority, that is the SAAA, with background and qualifications as a BSc in biology in the USA, an MB-CHB at Medunsa, and a master's in public health at the University of Pretoria. And Dr. Bogatso is a technical advisor at the United Nations International Civil Aviation Authority since 2009, as well as the chair of Agri-UN Africa, that's of the United Nations, the ICAO body that is from 2015 to date. And with that brief and short introduction as a means of a bio sketch, I hand you over to Dr. Bogatso. Dr. Bogatso, if you could just maximize your slides and check your audio. Thank you very much. I hand over to you.
Good morning. Can you see my slide?
Yes, thank you very much. It is maximized. Okay. And please just educate me in the pronunciation of your first name.
Lesego.
Thank you very much. Welcome. And thank you for taking the time for joining us and preparing We much appreciate it. Please proceed.
Thank you so much for the invite. So my name is Dr. Lesego Bokgatsu. I'm the Senior Manager of the Aviation Medical Department of the Civil Aviation Authority. As the chair already indicated, I chair a program of UN that actually looks at public health events of international concern. That includes communicable diseases, radiation accidents similar to Fukushima, and your chemical spills. I've just actually moved to the second slide, but it's not moving from my slide. From my side, is it moving from your side?
No, it's still on the first slide. And if there's a difficulty, our IT colleagues can share from our side. So just see if you use the arrow or the mouse to move yours.
I'm using the arrow.
Okay, so let's just quickly ask our colleagues, that is Tabani, if he could share your slides from our side, and that would mean you would have to unshare from your side, Dr.
right.
Bokgatsu.
Okay, we'll do that.
So in the meantime, a bit of admin for those of you who wants to ask your questions. There's been quite a bit of questions on the Q&A box. Please type it there in the question answer box, and our presenters and panelists would be answering it there. Also just remind Dr. De Vrij that I think there are some questions that may be specifically directed to you. And so Dr. Bokgatsu, you'll notice that my colleague Tabani in the IT section has shared your slides, and I think it's on the second one. I hand over to you.
Okay, all right. Thank you so much. Okay, thanks. Okay, so following the 2003 SARS outbreak in Hong Kong, the aviation community internationally, through the UN agency, identified that aviation sector was mostly hit. And in 2005, we anticipated another outbreak in Asia Pacific. And following that, a program called the Collaborative Arrangement for the Prevention of Public Health Events in Civil Aviation was actually established to ensure that there's mitigation of risk of the spread of communicable diseases from one continent to the other. The program itself, it's called CAPSCA program. It is a child of WHO and ICAO. Civil Aviation Authority, our office, comply with ICAO requirements, while the Department of Health actually complies with WHO International Health Regulations. Next slide, please. So ICAO, there it is. You've heard the Minister of Transport announcing on border opening. So we in South Africa actually report to Nairobi, and within the Civil Aviation Authority, we report to the Ministry of Department of Transport. Next, please. So ICAO have few regional offices similar to WHO, one in Nairobi for us in the East and Southern Africa, and in Cairo and Dakar for West Africa and basically French-speaking countries. Next, please. Within South Africa, so the International Civil Aviation Organization, which is the UN agency for which South Africa is a signatory to, requires us to actually comply with certain legislation. What ICAO does is that within the Civil Aviation Authority, there are certain annexes at ICAO that are actually drafted, and states like ourselves have to actually implement those regulations. We get audited on a regular basis, and the ones that are applicable to public health in civil aviation is Annex 6, 9, 11, 14, and 18. So within the Civil Aviation Authority, unlike WHO, we actually get audited on this. The results get published internationally, and if you do not score well, whether it's with regards to aircrafts, whether it's regards to your personnel or whether it's regards to public health, other countries can actually decide to not allow you in your airspace. So for example, for SAA and other operators to actually fly to other countries, they are audited based on the CAA's outcome audit. Next, please. So you have to press this one a number of times, please. So a few years ago, many years ago, it was estimated, again, please, Tabani, that with long haul flights and improvement in technology, operators are actually able to move from one continent to the other within a short period of time, within 24 hours. And we've seen that in recent times. And this means that passengers are actually able to move communicable diseases from one continent to the other. This was actually discussed quite a long time ago after 2003. And with that came the CAPSCA program, which aimed to actually ensure that containment of the disease in a timely manner, robust, coordinated nationally and internationally to ensure that there's harmonization of a contagion. Next, please. Sadly, this is not a new issue. As far back as 1944, the ICAO, International Civil Aviation Organization, wrote an article for which countries have to actually comply with. Article 14 actually said in 1944 that each state had to actually agree to taking effective measures to prevent the spread of disease through air navigation. And you can see that this is old because there are certain diseases that are actually mentioned here, like smallpox, that are actually not currently there. Next, please. And so it was important that with the civil aviation authorities and UN ICAO, that we coordinate with WHO to ensure that the IHR international health regulations are also implemented. Next, please. So ICAO then took that old document and then amended other annexes to actually updated, because from 1944, it was quite a long time ago. So Annex 6, which actually looks at the aircraft universal precaution kit on board an aircraft for cabin crew, communication between the pilot in command and ATC regarding a suspected case on board was actually amended. Annex 9 said that each state must have an aviation pandemic preparedness plan. In South Africa, we've had an aviation pandemic preparedness plan since 2016, and we do get audited on this. Air traffic controller, so everybody who is part of the communication system is actually required to have a plan. So airlines are required to actually have public health plans. ATCs have to have a public health plan. Airports have to have a public health plan. And Annex 18 talks to your dangerous goods. How do you actually transport human remains that have been confirmed to, for example, have COVID at the moment? How do you actually transport specimens from one country to the other when you're suspecting Ebola or you're suspecting COVID-19? How do you actually carry oxygen? Or how do you actually manage the issue of sanitizers, because they actually can ignite fire on board an aircraft? So we are actually audited on this, and we intend actually audit the aerodromes, which are your airports, whether it's AXA, non-AXA, air traffic navigation systems. We actually audit all the operators, SAA, locally and internationally. So before we actually open up, all the operators had to submit their procedures for us to ensure that they actually comply. We go out there and we actually audit operators, including charter operators, because some of them carry up to 19 passengers. Next, please. So CAPSCA is actually a baby of ICAO and WHO, as I've indicated. Without WHO actually, or Department of Health, implementing the international health regulations, the CAA and ICAO will actually not, the program will not be successful. So as much as we need to implement the ICAO annexes, the Department of Health have to equally implement the international health regulations. Next, please. So this is the role of the National Department of Health, and you can see that they are required to conduct some core capacities, Port Health, at ports of entries of international airports. Next, please. The program is actually global. So if you live here, you go to Singapore, we all one family, we have our own conferences in the continent. We've hosted conferences, a number of conferences in South Africa. Some conferences are actually global. Wherever you go, the program is actually harmonized. We speak the same language in terms of the CAPSCA ICAO program. Next, please. You have to press this one a number of times. So again, please. Again, and again. All right. So what we look at is actually before, each country have a duty to actually contain the spread before travel. So ideally at the moment, I think the previous speaker have actually indicated that some countries require a certain test like your PCR. We in South Africa also require that, but our airport staff are actually trained to ensure that they identify cases of suspected communicable diseases, and there are processes in place for them to actually report such cases and not allow the passenger to actually board. If a passenger is missed, passengers can take, if you're looking at fever, for example, we're currently looking at thermal scanners, people can always take Panado. If that passenger actually beat the system and is identified on board an aircraft, cabin crew is actually identified to actually identify suspected cases of communicable diseases. They have universal precaution kits on board, and there are doctors on board an aircraft. They will follow the process of all first calling a nurse, a paramedic, or a nurse, or a doctor. If not available, they'll actually manage the suspected case themselves. So there is a way, there's a procedure that has to be followed, and our office actually conduct audits to ensure that crew is actually trained and that operators have the necessary universal precaution kits to manage the suspected case of communicable disease. The pilot in command will be notified. He in turn will notify the ATC en route, who will notify the destination aerodrome. The idea is that when that aircraft actually lands, all the necessary stakeholders, including Port Health, the ambulance, the designated ambulance, because if you're dealing with a suspected communicable disease, you need a specific ambulance that should be able to actually manage that case with proper PPE. They will actually activate. There is a designated parking station that we actually look for, and all the stakeholders will actually meet the aircraft to make sure that that passenger does not actually enter the terminal building. If it so happens that the aircraft was actually close, if you go to areas like OR Tambo, there is an isolation room where the suspected case can be actually placed there. The isolation room ventilation system is not normally connected to the aircraft. The beautiful one that you can actually see is at Lanseria, because it's a little Zozo with obviously basic requirements in terms of ventilation. Next, please. So this is a multi-stakeholder approach. Even in South Africa, we sit at MNOT, we sit at net joints and other meetings or working groups that actually looks at the various issues. So there's one, you have to work with all the stakeholders in order for there to be communication, collaboration, and coordination for us to contain the disease quite timely. Next, please. So the purpose is to mitigate the risk from the pandemic, and we've had a number of experiences with regards to this. We had Patrick Swayze in Nigeria many years ago, and of course, we brought the disease to South Africa through Emirates last year around March. The idea is also to reduce the risk of spread on board an aircraft, but also to mitigate the risk from a pandemic at financial mitigation. So currently, we are seeing the consequences of what a pandemic can do to various businesses. Next, please. So what have ICAO done now? So we had all this legislation, countries were actually complying. However, the disease still spread. What measures have we put in place recently to deal with COVID-19? Next, please. We have a concept that we call the public health corridor, and we've developed various documents that looks at clean crew. So crew at the moment, we have a crew module that our operators have to comply with. Currently in South Africa and globally, crew are not required to actually provide PCR testing because they travel quite a lot. However, there are measures that are in place for them to ensure that they self-monitor and they actually use set specific or designated transport when they are doing layover. So there are specific guidelines that are in place to ensure that both South African and international operators comply with. Clean aircraft basically means what happens on board an aircraft. You have passengers that actually are wearing masks and you have crew that's wearing masks, but the aircraft itself, interior, there is a ventilation system. You've heard the Minister of Transport actually talking about HEPA filters. The airflow there is actually fascinating, and I'll speak to you about that. But we actually have disinfection processes that operators have to actually follow to ensure that there is proper disinfection of the aircraft. Clean airport facilities, there are measures in place to make sure that there's ventilation systems at the airport, that there's social distancing and other measures. Clean passengers, currently we're requesting actually testing, but passengers also have to wear masks. We do have fascinating experiences with passengers actually, especially locally, because testing is not required, not telling the truth about their COVID-19 status. And then we've got clean cargo. All these are actually looked after by the Civil Aviation Authority, and we conduct audits out there. Not only are operators required to submit procedures, but we actually audit them to ensure compliance. Next, please. We actually recognize that there is no single measure that can actually mitigate the risk of the spread of communicable diseases, that actually all the measures that are there, we know that the masks that everybody is using out there in the public are not similar to hospital masks. The filtration rate of those are actually limited. We advocate social distancing at airports. However, we know on board an aircraft, due to the finances, is actually not possible. Therefore, there are other measures in place, and we believe in implementing a multi-layered approach. So there's various layers in place that we've put in place to ensure that we mitigate the risk and minimize risk on board an aircraft. And during the entire travel, the risk remains present, however, is very low. Next, please. So multi-layered approach, we've started. Next, please. The first one is actually masks. We've had problems with passengers obviously wearing masks. However, there is a law, it is a COPTA regulation, but within the Civil Aviation Regulations Act, there is a regulations that talk to that. So there are passengers during especially December holidays that we've actually taken legal action against. We work very closely with the police. Next, please. Next, please. So enforcement is very important, and we work very closely with airlines to make sure that everybody actually complies. We do enforce regulations to the airports, to the airlines, and to the passengers themselves if there is non-compliance. Next, please. Enforcement continues to be very important, and we work very closely with various stakeholders to ensure that the police are waiting for the suspected cases. We've had problems with unruly passengers on board an aircraft, especially with the introductions of masks. And especially when there is alcohol involved, where crew have experienced challenges with passengers not wanting to wear masks. So what normally tends to happen is that this matter will be reported to the pilot in command, and when the aircraft actually lands, the police will be waiting for that suspect. Next, please. So one of the issues that we talk to our industry about, we try to go to town about education. So there's a lot of education taking place about the type of masks that are recommended and which ones are not recommended. Next, please. Obviously, there are exemptions to the rules. Children are not actually allowed to actually wear masks, but there are also passengers with certain conditions who are unable to actually tolerate masks. So, for example, those passengers with autism may not wear masks. However, they do need to present a doctor's note before to an operator, an airline, to ensure that indeed they actually suffer for such a condition. Next, please. So this is just an example of a typical shortcoming of the various layers of masks that are actually used and the filtering that they actually similar. If you compare an N95 to the various masks that you see out there in the public, the filtration rate actually for these large droplets are actually lower for some masks. And we make sure that our industry understand this so that education of passengers and others take place. Next, please. The education, very important. We use various measures, social media, radio, print, other measures to ensure that the public itself is actually educated and aware of the regulations. Next, please. Screening, major issue. We know that screening, the various screening measures that are there. Next, please. Whether it's a questionnaire, whether it's thermal scanners that we actually seeing at the moment, some of them actually lack scientific principles as prescribed by WHO. WHO have regulations and they do state what the screening measure is, but we know that these screening measures, most of them actually have shortcomings. People can take Panado, they need calibration, and these things are actually not taking place at the time. Sometimes passengers themselves are not presenting with symptoms. For example, we normally have fever. I can take Panado for that, but also if I'm not symptomatic, you're not gonna be able to actually pick the symptoms. But also if I'm also presenting with other symptoms except for fever, the screening measure, especially the thermal scanner, may not be able to pick up the passenger. Next, please. So next, please. It's actually slow from my side. Okay, next, please. So WHO have a different stand on screening measures, especially at airports. Initially, they had actually requested that countries actually had screening measures, but due to the limitations, I think most of them decided to issue a second document that said it was up to states. So currently, various states are doing various things and there is no standardization across the globe. Next, please. So you can either have a visual screening, you can have a brief history, all of which actually have limitations, as I've indicated. If you actually take history, somebody may not tell the truth. If you take temperature, they may not be symptomatic. If it's actually forms, people can actually not tell the truth. So the screening measures that are there actually have certain limitations. Next, please. Okay, so currently this is the normal process at various airports. Initially, the screening was actually conducted by Port Health. They currently conducting screening for international passengers. So the screening currently is actually conducted by airport security, and they refer you to the necessary stakeholders if you present with a high temperature. Next, please. So I've already indicated that the screening measures, most of them actually have limitations. Hence, our approach is that we actually use a multi-layer approach, taking into consideration the limitation of each measure that we put in place. Next, please. We make use of various resources that are available. For example, even when you check in, there are symptoms and signs that your check-in counters actually have. They are looking at you, and if they suspect that you may actually be symptomatic, they'll actually call the supervisor, who will in turn call the medical doctor, and decision will be made whether you are allowed to board an aircraft or not. Next, please. Okay, so how do we deal with the various measures in place? Obviously, we conduct risk assessment, whether it's actually at airports or within airlines, and we consider areas that are of high risk in terms of a number of passengers. So we know that specific areas at airports, before boarding, there's a large number of passengers there. En route to the airport, if you use public transport, you may actually be exposed. At check-in counters, and you'll see some of the measures that we've put in place. Waiting in the waiting area, there may be a problem, or access to the aircraft jetway, there may be a problem. So these are identified risks where we've actually put mitigation to ensure that there's social distancing. Next, please. So this is a typical example of what happens when you go to the airport. On basically lifts, you will see that there's social distancing posters everywhere. Within chairs, we try to ensure that there is social distancing, and within the airport itself, that there is social distancing of at least 1 meter. We started off with 1.5. However, the space constraints had to force us to actually go to 1 meter. Next, please. In terms of boarding, there are boarding rules as to how to board to ensure that you minimize a number of passengers, a large group of passengers boarding an aircraft at the same time. Next, please. So those of you who have flown recently, you would have actually observed that even when you actually take off, when you land and you have to actually get off, the cabin crew will actually control the number of people who actually leave the aircraft or disembark at the same time. Social distancing at the airports, we use various apps to minimize contact between airport staff and your passengers. Next, please. So challenges, social distancing, especially when you have a large number of passengers. So in December holidays, we actually had serious problems with space, and we saw a bit of non-compliance, which we actually took care of from airlines and the airports in terms of not managing overcrowding. They do have people who are actually delegated to ensure that COVID-19 procedures are complied with by passengers and other staff members. Next, please. So disinfection of the aircraft or disinfection at the airports. So you will see sanitizers at various levels, and we've looked at highly touched areas within the airport. So various areas within the airport would actually have disinfection measures, and you will see that staff is actually appropriately dressed to ensure that they themselves do not get sick. Next, please. The buses, in terms of disinfection of the buses that actually operate at the airports, are required to submit procedures to our office, and we actually do go there to assess whether they comply in terms of numbers of passengers on board those buses, but also in terms of the disinfection of that aircraft every time they actually drop off passengers. Next, please. The passengers with disabilities, obviously they normally use airport wheelchairs, and these have to be disinfected at specific times. Next, please. So areas that are highly touched, we actually manage that. For example, your escalators have to be actually disinfected all the time. Next, please. Okay, so next, please, because I've already indicated that we actually use various measures. So what IATA did, IATA is the International Airline Association. At the beginning of the outbreak, they actually developed a risk stratification document to assist operators determine their level of risk. And based on your level of risk, then the intervention had to basically match what your risk was. So they looked at local transmission. As you are aware, we are community-based, a number of book passengers. If it's not full load, then you are a certain score. If it's full load, the length of the flight, how long is it? Is it less than 4 hours? Is it more than 4 hours? Is it full? Is it not full? And we actually come up with risks to know which operators are actually, or routes are actually low risk, which ones are medium risk and which ones are high risk. And then we are able to actually come up with mitigating factors. Next, please. So on board an aircraft, we know that there has been queries, especially from the taxi drivers, that we were allowed to actually fly with 100% passengers. And there are things that we consider on board an aircraft when we look at a suspected case of communicable disease and the risk of exposure. Basically, we look at proximity of the index case, infection specific features of what are we dealing with. Is it Ebola or is it COVID-19? The virulence, the aircraft configuration. Does that aircraft actually have a ventilation system? Do they have HEPA filters? Because not all of them actually have HEPA filters, and other measures in place. Next, please. We do know that microorganisms have been found to actually linger around in the aircraft, and there are studies that have actually demonstrated that previously. Next, please. However, within the aircraft, there are certain factors that lower the risk of COVID-19 transmission. For example, the seating and passengers actually face forward, meaning the barrier, the solid barrier of the seats act as a protective measure. And research actually suggests that the aircraft's interior, the ventilation system, airflow is very high, and it's actually exchanged every 2 to 3 minutes, and basically similar to your hospital theater rooms. Most modern jet aircrafts actually have what we call HEPA filters. So 50% of air that actually is recirculated on board an aircraft go through a HEPA filter, and a HEPA filter is actually able to filtrate about 99% of the microorganisms. Next, please. The airflow starts on top and it actually goes down. So the nature of the aircraft itself, the airflow, the ventilation is quite protective. If you do have a suspected case on board an aircraft, normally you'll actually follow passengers who are sitting 2 rows in front, 2 rows behind, and 1 meter away from those. So you're able to kind of map up who your suspected cases are. Next, please. So there are various measures on board, as I've already indicated. Your crew actually have, where, especially when they fly long haul flights, you can see with the Emirates flight crew, they will wear goggles and they'll actually wear a mask. If there is a suspected case on board, they will then wear a universal precaution kit if they actually managing that. Discarding the fluids and anything that's suspected case related is actually disposed in a biohazard bag. There are measures in place to make sure that crew does not actually exchange blankets on board an aircraft, and we've developed guidelines to ensure that crew is aware of the impact of CPR on board an aircraft, which may actually cause aerosolization.
Apologies, Dr. Bakatso. Just
yes.
2 more minutes, thanks.
2 more minutes, okay. There are measures to ensure that disinfection take place, and as I've indicated, you actually have a way of transporting your blood samples or other samples in a way that it's packaged according to you and to mitigate the risk of spread of disease. Next, please. So this is typically what happens on board an aircraft. Next, please. Safety demonstrations to make sure that crew does not actually expose each other. There are rules on how they should actually conduct safety demonstrations. Next, please. So you see the impact currently of COVID-19 in terms of the numbers, very reduced travel globally. Next, please. Universal precautions kits, I've already talked about that. We actually look for them, and we've obviously had to amend them. They are amended every time there is an outbreak based on the type of disease that is out there. Next, please. Operators are also required to have first aid kits and doctor's bag, and I've already talked about. Next, please. So I've talked to you about boarding and disembarkation rules. So operators then control the number of passengers who actually board and who disembark to ensure social distancing. Next, please. In terms of sanitizers, there are rules on sanitizers and how much you can actually take, because sanitizers actually they are considered to be dangerous goods and they may cause fire. So as a passenger, one has to consider those issues, and operators have had to consider that with COVID-19 because there was a need for an increase. Next, please. Crew precautions, I've talked to you about that when they get to other countries, they avoid public transport and they basically stay in their rooms to make sure that they are not exposed to other people while they actually on layover. Next, please. There are various forms that our crews have to complete as they travel globally to ensure that they comply with these rules. Next, please. Studies on transmission of COVID on board at the moment, especially with COVID, are very minimal. For now, we know that the risk with the current studies is actually limited. I'll stop there because I still have a lot of slides to go to, but I'll stop there for now.
Thank you very much for that. That's Dr. Lesego Bogatsu. The presentation slides will be made available to all of our attendees, and I'm going to encourage Dr. Bogatsu just to look at the Q&A box there, and there are questions that can be answered, as well as if you have follow-up questions, we may be able to, with Dr. Bogatsu's permission, direct you to her afterwards. Thank you for that. Without much further ado, I'm going to hand over immediately to the CEO of Tourism Business of SA. That's the TBCSA. I think I've got that right. I suspect the word council somewhere in the name. You can just correct me. And that's Mr. Tsifiwa Tsivengwa, dealing with the topic of travel and tourism protocols. And whilst the presentation slide is being prepared, by way of introduction, he's a tourism executive with over 17 years experience in the international marketing, business development, international trade relations, among others in tourism. Tsifiwa brings the strategic focus and versatile business judgment gained during the Los Angeles, New York, and working in these different cities globally and in South Africa. It's also best described as a social entrepreneur who founded Zote, Z-O-T-E investments and project, where he partnered with various organizations in the USA, New Zealand, UK to bring over 400 international volunteers to contribute towards youth development in the Limpopo province. Now, there's much more I can share here. He's currently the CEO of Federated Hospitality Association of South Africa, and he holds a BBA Marketing Communications Diploma in Marketing from the Institute of Marketing Management and a National Diploma in Tourism Management from the University of Johannesburg. Busy with Masters in Science Strategic Planning at Edinburgh Business School. With that, I hand over to you. If you could maximize your presentation slide for us, please, and just check your audio. I hand over to you, sir. You might be muted. If you could just check your microphone.
Hope it's still, good morning, everyone. As introduced, my name is Tsifiwa Tsivengwa. I'm the CEO of the Tourism Business Council of South Africa. And I will be following on to what the other speakers have shared and pretty much sharing what is it that we've done from the tourism point of view to mitigate the risk of COVID-19 spreading across the value chain of tourism within South Africa. I have been listening attentively from previous presentations in terms of what is going on within COVID, what is going on from the medical point of view, and also what is going on from the airports or aviation point of view. And of course, our sector, as the tourism sector, it's quite large. It covers various subsectors across the entire value chain of tourism, and sometimes it can be very, very difficult to manage, especially during this time, of COVID, because you have the hospitality side, and you have got, the attraction and the experience side, and you've got other sides like your property size and so forth and so on. But I'm just going to share with you what is it that we've done to de-risk the sector, for both our employees and those that visit our establishments, to ensure that we are not considered as a super spreader industry. Okay, so tourism, it's not very much a well understood, sector of our economy. And you see this by the way the decisions are made, and how some of the decisions that we consider as not making sense do impact the tourism sector. You would have seen with various restrictions that have been put out since the beginning of lockdown and the subsequent introduction of the risk-adjusted strategy. There's been many things that have been banned that we believe did not make sense, including not allowing people to go to the beach, as an example, and not allowing people to go to the parks, as an example. And as the previous speaker have said, that some of these decisions are politically based, and some of these decisions don't deal with the problem at its source. In essence, if there's an outbreak in one suburb or township, the whole country gets to suffer. And we don't believe that makes sense. But just to share the value, the economic value of tourism in SA, this is pre-COVID numbers, 8.6% total contribution to GDP, 120 billion rand worth of forex coming into the country, meaning that tourism is an export. We're earning money from people coming into this country. And if I'm not mistaken, we're the third largest export, from that point of view. 1.5 million, people or jobs are supported by tourism. This is far larger than mining, as an example. And you would have seen that, in the beginning of easing of restrictions, mining was one of the first industry to be allowed to operate, and a lot of people went underground, together, and they were able to work. But we were not even allowed to work, even if we were socially distanced or operating a lodge that's sitting within the Kruger National Park, that is, far from everyone else. There's a lot of SMMEs within our sector, plus or minus 49,000 SMMEs, and you can see that the total spend in 2018 in travel was 273 billion. This means it's 120 billion worth of international travel. The rest is, local travel or domestic travel. And you can also see how, we spend within casinos and restaurants. And that just shows how large, this industry is. We also impact, the capital and supply chain in terms of building, renovating, making sure that there's new infrastructure within tourism. You can see that we're talking around 206 billion rand. We also consume locally manufactured vehicles, 12.5% of locally manufactured cars are bought by car rental companies. 8% direct impact on retail sector, meaning that many shops within many malls, especially close to the borders, are very much supported by those that are traveling into the country to spend a night or two and do their shopping and go back home. And there are many, many malls that are dependent to that. If you go to Nelspruit, it's the same thing. You go to Musina, it's the same thing. In fact, if you go to Sandton and you see how many people travel from Angola and many other places to come and shop, especially high-end products, you will see that there are many people that come into our country, to do shopping. And of course, we do impact manufacturing services, fuel, construction, agriculture, and so forth and so on. The TBCSA, this is called the Tourism Business Council of South Africa, was established in 1996 to represent the interest of the private sector within the tourism industry. In essence, our main job is to make sure that we lobby for the interests of the private sector to government and make sure that the trading conditions on the ground are good enough for tourism to thrive and also to attract more people into the country. It simply means that during this time when we have COVID and when we have regulations that are coming on frequently on the basis of the Disaster Management Act, we have to be more vigilant to make sure that the regulations that are out there are conducive for tourism, to restart and the recovery of the sector, to progress. So it is something that, at the core of what we do, lobbying or advocating is one of the most important, aspect of our work. And of course, we're a member-based organization, and our membership, cuts across the entire value chain, from airline associations, both international airlines and domestic airlines, to bed and breakfast, to car rental companies, to the hunting associations, and so forth and so on. So we touch every aspect of tourism. And I've talked about, a little bit about our mandate. We engage in lobby government on policies and legislation. We do research, data collection, and analysis to inform the tourism agenda. We influence public sector destination marketing programs. This is when the likes of South African tourism decide how to market the country. We influence that because we are the ones who actually receives the tourist and transact with the tourist and make sure that the money stays within the country. Of course, we promote transformation and growth, and we do collect what we call the tourism levy. And of course, communication is key across the industry, especially during this time. This is just to show you some of our association members that cuts across the various value chain of tourism. I'm going to get into the protocols and why we get into protocols and why it was important for the industry to develop these protocols. You all know that last year around this time, that is when the first shutdown or lockdown was being talked about, if not announced already. And I think, if I'm not mistaken, it started on the 27th of March, whereby we went on our first lockdown, and we were told that is to get the medical facilities ready, and to make sure that we are prepared, and so forth and so on. And then before that initial lockdown finished, the risk-adjusted strategy was introduced, and various levels of lockdown were introduced. And we found ourselves as an industry in the middle of this, because, of course, the case of COVID that came into the country, it came because someone traveled somewhere. And in nature of us as human beings, we all travel somewhere. And it was, it was going to happen either way, that someone will travel somewhere or someone will arrive here from another country, and the spread of COVID, will start, and there will be community transmission and so forth and so on. So we're in the middle of it. And of course, travel was seen as, the people that brought COVID into the country. And we were called names in various quarters. And we were literally not even allowed to say anything, because we were seen as the ones who have caused these problems. We've had to defend ourselves and show, everyone, including government, that, people travel anywhere, be it domestic, be it international, people travel, be it for work, be it for leisure purposes, be it for conferences, and so forth and so on. So people do travel. It's part of who we are. We've been traveling for ages and ages. Now it's just that, there are different modes of transportation that makes travel easier and faster than before. So we found ourselves in a position whereby, we were never going to be opened anytime soon. And we sat and started to think of, how do we de-risk the sector? And we said, well, let's develop the industry protocols. And these are health protocols that are going to be applicable across the value chain. So we pulled together all the various associations that are part of our membership and those that were not part of our membership. And we said, we got to think of, how do we make sure that people can trust us again? And how do we make sure that we are super clean? You would have known that, as a hospitality and tourism industry, we naturally a very hygienic industry. And to step it up to the next level, or to the level that was required, or that is still required, it was not a difficult thing to do. So we developed a few things. One, we developed the industry protocol document. And this document guides, the likes of restaurants, hotels, the car rental companies, It also goes into those that are in the lodges and everywhere else to say, how do we operate? As an example, the issue around, the restaurants was, how do we make sure that we sanitize the tables? How do we make sure that, there is compulsory wearing of masks? How do we make sure that we clean more frequently to show people that, people can still come and eat out, and we won't be, the spread of the virus is going to be minimalized from those settings. So we did that from the restaurant point of view. And you can imagine that, you've got formal restaurants and you also have informal restaurants. The two don't operate on the same levels. So we struggle a lot to get, especially from the semi-formal and informal restaurateurs to comply with the protocols. But as time goes, and as many people start to see the seriousness of COVID-19, we started to see a whole lot more people, adopting, these protocols. So you've got, the hospitality side, which will include restaurants. It will include, the hotels. How should they operate? How do we handle the swimming pools? How do we handle the reception areas? Putting up of perspex screens, and how do we make sure that temperatures is taken when they enter the buildings? And how do we make sure that the social distancing within the building themselves, and also at the dining area? We went as far as, from the hotel point of view, to suspend all the buffets, to say, well, we're gonna do food parcels for breakfast, as majority of our establishment sells, bed and breakfast. As time went, we then moved into saying that, the staff from the hotel can dish out the buffet, as an example, instead of everyone touching the spoon. So there will be one person standing behind the screen, and then they can dish out to those that are there for breakfast. So that comes at a cost, and you can imagine that the industry was on a standstill, and we will reopen sometime in July, August, and a lot of people had to invest more money to ensure that there is some level of compliance that will be satisfactory for us to open. So the policy document guided the establishment in a way that they will be able to prevent spreading of the virus to their own staff, meaning that there has to be something that's done within that environment for those that work there. How do we take temperature? For those that work there on a daily basis, how do we put records together? How do we make sure that we comply with the POPI Act? And how do we make sure that there is no spread within the workers within our environment? And then the next phase is to make sure that anyone who visits us, is screened, and they're also protected from COVID-19. So that protocol document covered the entire value chain of tourism. And of course, we couldn't go to every aspect, but we went to the major aspect because other aspects can be adopted. So you can adopt, what happened in hospitality can be adopted to other parts that are similar to hospitality. Same as in accommodation, they can be adopted to other parts that are similar to that. Car rental, the same thing. So after we've done that, we then pulled together what we call an app. And maybe perhaps it's on the next slide. But let me just stick to this one so that I can explain the rest of the slide. So we put together an app. We got together with the industry players, especially from food, delivery or food preparation side of things. These are the likes of Bid Food, the likes of RCL, and other major companies that distribute food. The reason why we did this is because they saw that if restaurants and the hospitality sector is not working, they lose business. So how do we make sure that we work and we apply technology in what we do? So we introduced an app on top of the protocol document. In essence, the app housed the protocols, and it made it easier for the employers to register their employees when they come to work on a day-to-day basis and keep the records, on the app instead of keeping it on a manual paper. And this helps us with compliance with the POPI Act to make sure that we're not found wanting from that point of view. So the app deals with that, and also it deals with registration of the patrons that are visiting, the establishments, to make sure that everyone that comes in, they're screened, There's a record should the Department of Health, come and look for that record. So that app is there, is being used. A whole lot of establishments are using it to make sure that the industry is de-risked. The third part of it, we developed the website, which ensures that those that cannot have access to an app for some reason, they can get the same information on the app. And that information helps them, they can get the same information on the website to help them promote, safety within our industry. And that website, we sort of branded it slightly different to what we do. We call it travelandeatsafe.co.za. And we're busy expanding on that to make sure that those that have been trained and that have complied with the COVID-19 tourism protocols are recognized so that we can push for more adoption within our sector. And then the other pillar, or the last pillar, is the training. Then we develop a training manual for the staff to make sure that the staff within the tourism value chain are trained, they receive a certificate, they know what to do on a day-to-day basis, and more special for small businesses that may not have the means to do training like that. Training, it's very much geared to that, and it's going to be scaled up as we work with government to make sure that majority of people are they're complying with COVID protocols, and as well as the norms and standards put by government. Now, you can see here the website that I was talking about, the Travel Safe, Eat Safe website. You can see how it works, and you can see how we've created a logo that ensures that every establishment that have gone through this protocol training, they can be able to put this logo on the establishment. Another thing that we've done, we took the protocol document that we created and subjected to World Travel and Tourism Council protocols to see if our protocols have that meet that global standard. And the WTTC came back to us and said, yes, your protocols do meet the global standard, and they gave us the stamp of approval, which means that our protocols here in South Africa are globally recognized as the protocols that meet those standards, like any other country in the world. So you can see the website, Travel Safe, Eat Safe, encouraging establishment to make sure that everywhere there are patrons that want to do tourism, they can do so safely, and the industry is de-risked. You can see the app that I spoke about. It covers restaurants, hotels, game lodges, accommodation, transport and tours, events, venues, activities. We continue to expand it as we go to make sure that all aspects of tourism are covered. You can see that there's a pledge and certification, and you can see the screening that I've spoken about, and you can see also the issues around staff PPE and cleaning registered instead of doing it manually. You can see the training side of things that I've spoken about. It's free, online training for businesses and staff. You can see that we focus on 5 subsectors, which is accommodation, those that have vehicles, dining, attractions, and activities. And there are modules, and once one finishes, they get a certificate. And we're also exploring other channels to make it more accessible in the informal sector of tourism, and we're in talks to make sure that this happens. And the Department of Tourism is going to be working with us. All in all, once one is finished, you're able to get this type of certification, that you can put on your window to show that not only are you compliant with the local protocols, but this meets the global standard. So this is what we had to do to de-risk the sector, and this is what's in practice. I'm not saying in no way we are perfect. There's still a long way to go. We are a vast industry. We have done very well in terms of making sure that we're not super spreading this virus. And I do believe, like other speakers have said, that traveling is safe, provided you follow the rules that we've put out, provided you wear your mask, you social distance, and when you arrive at our at our establishments, these rules will be applied. And failing so, the person will arrive there, we can reserve the right to accommodate them. And I think that, this is something that that's very significant, within the realm of tourism in South Africa. And that's all I'm going to cover for today. And thank you very much for having me.
Thank you very much. We are short in time and running over time, and I'm going to immediately ask Ms. Pam Masilela to share her slides. And whilst that happens, by way of introduction, Sipishishle Pam Masilela, apologies, is a Deputy Director working in the National Department of Health, responsible primarily for the port health policy, including coordination of the provision of port health services in South Africa. This includes monitoring service provision and ensuring services are provided in line with international health regulations 2005 edition and applicable other South African legislation. She's been employed in the National Department of Health since 2012 and played a critical role in the assessment of the core capacities of all points of entry and the transfer of port health services from provincial level to national level, and instrumental in the development and implementation of policies during public health events, including the Ebola outbreak in 2014, and most recently, obviously, the COVID-19 pandemic, and therefore she's one of our guests today. Prior to being employed by the National Department of Health, she worked at the OR Tambo International Airport in Johannesburg between 2006 and 2012, where she was appointed as the Port Health Officer and progressed to being an Assistant Director before moving to the National Department of Health. She currently holds a bachelor's degree in the field of environmental health, and with that, I hand over to our environmental health expert, that is Pam Masilela. I can see your slides, and just to check if your audio is okay, please proceed.
Thank you very much for the introduction. Good morning, it's still morning to everybody online. Firstly, just to thank the National Institute for Occupational Health for inviting us to come and share a presentation on port health services. So I'll just be taking you through what service we are providing within the ports of entry and what are the measures that we are implementing in response to the COVID-19 pandemic that we are currently experiencing. So just to jump straight at it. Okay, let me try and move my mouse. In terms of the background, what is Port Health Services? It's a service that is the responsibility of the Minister of Health. So as it was indicated in my introduction previously, it was a service that was provided at a provincial level, and the decision was then taken by the cabinet members to transfer it to the National Department of Health. So it solely sits with the Minister of Health. And it's a service that has, the main mandate of the service is to prevent, control, and provide a public health response to the international spread of disease. And not only diseases, but we also look at other public health risks. So there are other sections, for example, the importation of consignments and goods in ports of entry that we would look at. But the main purpose is basically to protect the health of the population from risks that arise as a result of international travel and trade. So we basically health police, if I can put it that way, to simplify it. We define the service as a first line of defense and to protect the citizens of the country against the health risks that are associated with the movement of people, conveyances, and imported cargo. And we say here, first line of defense, because when any traveler is coming into the country, the first point of call is a port health official, or the first point of call should be a port health official. We know in the land ports of entry, this is still a bit of a challenge because of the layout of the ports, and because when the service started, the land ports of entry had already been operational. So we entered into the fray a bit late, and the layout did not align or was not conducive to us being the first line of defense. But fortunately, with pandemics such as this, it elevates the responsibilities of port health, and people become more aware of our role, and there's a complete shift in terms of how processing is happening now in all the ports of entry. And we are providing the service in all the different modalities. So we are available at the airports, we are available at the seaports, and also at the land ports of entry. And primarily, the service is provided by environmental health practitioners, which are known as port health officials. And they are supported by nurses in some of the ports of entry where we have nurses, and also other health professionals. So when it comes to OR Tambo and Lancero International, we've got nurses that are appointed by the National Department of Health that are providing services at those airports. And then in other points of entry, there are arrangements that are in place with the nurses from the districts level and also the provincial level to provide that support when there is a need to have a nurse at the port of entry. And we also work quite closely with provincial EMS, so this would be in relation to the transportation of any suspect case or suspect traveler from a port of entry to the health facility for further management. So in relation to COVID, the main responsibility of port health is for early detection of suspect cases, and this is implemented through a multi-layered screening approach. There's a different screening measures that we are implementing, and then obviously then once screening is done, and if we do identify a suspect case, there is a response interventions that are put in place to address and to respond to that case. And we also, in addition to that, monitor compliance to the COVID-19 legislation. A lot of speakers have already spoken about the legislation that has been put in place in relation to COVID-19, and those that are applicable to the points of entry and indicated or promulgated by or signed by the minister and also the Minister of COGTA that are health related. We would be the ones who are enforcing that together with other government departments that we are working with. So this is just a map of the ports of entry in the country. In total, there's 72 ports of entry which are designated by the Minister of Home Affairs. And in those 72 points of entry, we are providing full-time services in 37 of those ports of entry. The 72 ports of entry comprises of 10 airports, but I've indicated here that it's 11 because we also provide services at Waterkloof Air Force Base. So once it's activated as a port of entry, we provide services there. So there are 11 airports, we've got 8 seaports and 53 land ports of entry, land borders. In the ports of entry where we are not based there full time, we do provide ad hoc services. And mainly it's those ports of entry, even now with COVID-19, that have been closed since the start of the national state of disaster on the 27th of March. So there isn't too much movement in terms of the volume of travelers, and many of those, they don't even process other commodities such as cargo. So we provide a service on an ad hoc basis. I spoke about the multi-layered screening approach that we are implementing as Port Health Services. And here is just to outline what are those measures that we are implementing. One, the first is we monitor the arrival of conveyances, so international conveyances, and this is in line with the international health regulations requirements. And mainly when it comes to conveyances, so if I can use an example, when an aircraft comes in or lands in one of our airports, the first people who would board that aircraft would be our officials, would be Port Health officials, and they would interview the crew to find out if there wasn't any sick passenger on board during the flight. And also there's a specific documentation which we call the General Declaration of Health that the crew also issue out or give out to Port Health, where they declare that there wasn't any sick passenger on board and there wasn't any public health risk on board. So that's the first level. Before the passengers can actually get out of the flight, we would have determined through the interview and the engagement with the crew members that there was no sick passenger on board. From there, then, as a traveler, you would then get out of the aircraft, you would come through the international arrivals hall, and the first people that you would see is a Port Health official. So in the context of COVID, you would issue out a completed traveler health questionnaire. And in that questionnaire, that's where a traveler would then indicate their personal details, they'll indicate their travel history, they'll indicate if they're experiencing any symptoms related to any disease, and in this case will be specific to COVID, and then they'll also sign to declare that the information that they have provided is correct and is true. And the Traveler Health Questionnaire assists us in identifying a history of exposure, in identifying if a traveler has had symptoms that are related to any communicable disease or infectious disease. And from there, then the next step is the taking of the temperature. And there's two equipment that we use here. We use the thermometer and we use the infrared scanner. So in all ports of entry, they have the screening tools or screening equipment, and passengers are taken through this process so that we can then determine whether they do have an elevated temperature or not. The previous speaker has already indicated in terms of the limitations around temperature screening, but it is still an important tool that we use as Port Health to determine whether a traveler can be deemed as a suspect case or not. And then we also have temporary isolation facilities within the ports of entry. So if during any of these stages a traveler has been deemed as a suspect traveler, they would then be temporarily isolated after the secondary screening has been conducted, and they'll remain in isolation until then the EMS comes and takes them to a health facility. So in general, this is the screening procedures that we are implementing. Specific to COVID, so if you are traveling overseas, whether it's for work purposes or any other purpose, what can you expect when you come back into the country? First of all, it's the primary screening measures that I've indicated in the slide earlier. There's also an element of visual observation where our officials would see whether you visually look well or unwell. And obviously, if you look unwell, then they would then ask certain questions to try and get an understanding of, the reasons behind, why you looking the way you are, and determine whether should you be considered as a possible suspect and maybe taken to secondary screening. There's also the issue of the Traveler Health Questionnaire that I've already alluded to, and the taking of the temperature. So when you come in, this is what you can then expect to be taken through these sections. And if for any reason you look unwell, if you've indicated in the Traveler Health Questionnaire that you have signs and symptoms that are related to COVID, or you've indicated, or we can see through the responses that you've given that you do have a history of exposure. One of the questions that we ask as an example is whether you've been in contact with somebody who was either a suspect or confirmed COVID-19 case, and then you would then indicate, and that would obviously be a red flag to say you've had that history of exposure. Or if during the temperature screening you were found to have had an elevated temperature, then you are then referred to secondary screening. And secondary screening is primarily conducted by the medical personnel, the nurses within the ports of entry. And this is where they would take then your core temperature, because if you look at the temperature screening equipment that we are using, it does not take your core temperature, it basically takes your skin or your facial temperature. So during the secondary screening, then they would take your core temperature, and then it would then be followed with an in-depth interview. And in the ports of entry where we do not have nurses, the port health officials would conduct the in-depth interview. And then based on the outcome of the secondary screening, then a decision would be made on how the traveler will then be managed further to that. So I also indicated that we also enforce or monitor the regulations that have been put in place in response to the COVID-19 pandemic. And I'll take you through now what is contained. So this is what is legally in legislation that has been promulgated by government and also by the Department of Health in terms of travelers who are coming in and going out of the country. So for travelers who are exiting the country, they will be subjected to exit screening, which comprises of all the elements that I've mentioned in the previous slides. And those that are found to have an elevated temperature will be subjected to the medical examination. And in certain cases, that medical examination may include testing. And then based on the outcome of the medical examination, a decision will then be made to either allow the person to board or to continue departing the country, or to keep the traveler from traveling. And we do this because we have an obligation in terms of or in line with the World Health Organization requirements, that as a country, we are experiencing community transmission, and we do have a responsibility to protect other countries. So we need to make sure that everybody who leaves South Africa is not or could not potentially be infected with COVID and may potentially spread it to another country. So that's what we implement when it comes to people who are leaving the country. When you are entering the country, the legal documents say you also are subjected to screening. If you are found to have an elevated temperature, you will be subjected to medical examination, which may also include testing. But in addition to that, every traveler that is coming into the country, into South Africa, must produce a COVID-19 PCR test result that was obtained not more than 72 hours from the date of departure. And this is a requirement that is in multiple legislative documents. The Department of Transport has legislated this, particularly for your air travel, and also the maritime travel. And the COPTA regulations also stipulate this together with our regulations as health. And I think also the Home Affairs regulations have also stipulated this requirement of the COVID-19 PCR test results. If you come in for whatever reason and you do not have a negative COVID-19 PCR test result, then you will be subjected to antigen testing, and this will be at the cost of the traveler. So in all the ports of entry where international travel is permitted, we've got the National Health Laboratory Services that are there, stationed there, and they are the ones who are administering the antigen testing. And based on the outcome, then if the person is found then to be positive, they'll be taken to quarantine, and a PCR test will be done on the same day, and then they will then await the outcome of the PCR test results before then a decision can be taken on whether you either negative or you are positive. And all travelers that are arriving into the country are encouraged, we encourage all of them to install the COVID Alert SA mobile application on their mobile phone. There are exemptions when it comes to the producing the PCR test results. So we've got daily commuting learners who come in and out on a daily basis through our land borders, and also teachers who live in our neighboring countries. They are exempted from producing the PCR test results. Children under the age of 5 years are also exempted. The cross-border freight operators, the medical evacuation crew, and also the airline crew. So these are the categories that are exempted from producing the PCR test result. I think the first speaker also spoke about frequent travelers, or person who's a business traveler who's coming in and out of the ports of entry, through the ports of entry within, a short period of time. And these type of people, we define them as frequent travelers. So if you are commuting between the South African ports of entry on more than one occasion within a 14-day period, you are defined as a frequent traveler, and your test result remains valid for a period of 14 days. So it doesn't mean that every day you enter into the country, you need to have conducted a new test. So it remains valid for 14 days, and then after 14 days, then you need to then go and take another test. And airline crew that are permitted to lay over by the Department of Transport, they're allowed to do so in their own facility. They can identify their own facility, but we would need to be informed as Port Health, and the employer is responsible for monitoring the crew during the layover period. And then in terms of the cargo and the vessels or the maritime environment, the requirements are also still the same. We know that vessels can spend weeks on sea, but a crew member who, when they join the ship, they sign onto the ship in whichever country, they should sign onto the ship already in possession of a COVID-19 test result, and then we will then check it on arrival into the country to ascertain whether, when they boarded the ship, were they negative or otherwise. Okay, and then the reporting and notification. So Port Health forms part of the surveillance system of the country. It forms part of the reporting and the notification system of the country, because there's a lot of public health risks, which include communicable diseases and other illnesses, issues around malaria. And I think it was also mentioned that a majority of the people that actually come into the country and are picked up, you find that they suffer from malaria. And as a country, we've got a responsibility to report to the World Health Organization, firstly through our local reporting systems, which it would then go to the international health focal person who sits in the National Department of Health under the cluster communicable disease. So any incident that happens at a port of entry is reported to the IHR or International Health Relations focal point. And there's an assessment that is then done by the focal point and a determination on whether it's information that then needs to be reported to the World Health Organization. And the World Health Organization can then report it to other countries so that other countries are aware that there is a certain incident or there is a disease, a communicable disease that has originated or that is being responded to in a country. And then it allows other countries to then also have their own response mechanisms in place when it deals with that. So I mean, a classic case is what we are dealing with now, the COVID-19 pandemic. We were informed, or countries were informed by the World Health Organization that there is this event that is happening in China, and then countries then were expected to respond and put in measures, additional measures in their ports of entry to try and prevent the introduction of, or even not prevent, because I think we knew that it wasn't a matter of whether it's going to come in, it was just a question of when is it going to come in. So it just allowed us to be better prepared for the first case that would be entering through the ports of entry. And if for whatever reason a traveler is identified and they are positive, they've been taken through the testing, antigen testing, and they've been found to be positive, or if there is a report on board the aircraft that the traveler was exhibiting symptoms that are consistent with COVID, and subsequently the test result came back as positive, as Port Health, we are also responsible for identifying the contact. So everybody that case could have been in contact with, and this information is communicated to CDC, and then they would then start doing the contact tracing procedures and the protocols that are currently in place. And as a traveler, you also are the port of entry that you are traveling through. The authorities, they have a responsibility and an obligation to adhere to the COVID-19 protocols that have been introduced by government. Whether you're traveling through an airport, you are traveling through a seaport, or you're traveling through a land port, the landlord or the authority needs to ensure that they have the containment protocols in place within that facility. So they need to provide resources that enable public hygiene in the ports of entry. They need to provide hand washing facilities and sanitizers so that travelers and anybody else who is using the facility can have access to. They need to ensure that there is adherence to social distancing. This is whether it's through floor marking, stickers, through other visual aids, but it needs to be put in place within the facilities. And there also needs to be a frequent environmental cleaning and disinfection of the port of entry facility that is used by the travelers. And they're also responsible for monitoring that masks are being worn by all persons that enter the port of entry facility. And they also need to provide reciprocals for the disposal of PPE or any other infectious objects. And also they need to have contracts in place for the collection and the transportation and disposal of the healthcare risk waste that is generated both at the port of entry and that maybe have been generated on board the conveyance. And there's protocols in place around the management of healthcare risk waste that was generated on board a conveyance. And I think Dr. Bogato also touched on some of that. Okay, and then as a department, we are moving towards digitizing the traveler health questionnaire that I was referring to earlier. So instead of it being paper-based, we now want it to be digital. And we are currently at a phase where we are piloting this concept in 3 points of entry. We're piloting in OR Tambo, in Cape Town International, and in Beitbridge. And basically it allows you as a traveler, when you are traveling, you enter into the site. So there's a link to the site. You enter into the site and you complete all the health questionnaire, or the questions that are in the traveler health questionnaire you completed on your smartphone, for instance. And once you've completed it, you then send it through, and then you get a unique number. And when you get the unique number, Port Health is also then alerted, and your information goes into the database of Port Health. On arrival or on entry into the country, you produce your unique number, and the system automatically then, based on the information that is provided, and then the temperature that would have been taken by a Port Health official, because when you arrive, they will still take your temperature and they'll input it to your specific response questions. And then the system will then indicate whether you can proceed with Home Affairs processes, or you are flags you as somebody who needs to be referred to secondary screening. So it's more of an automated process that we are introducing within the port of entry, and we are getting the support from the Clinton Health Access Initiative. So hopefully in the next few months, we'll be able to fully roll it out in the points of entry. Coordination and collaboration, a very important aspect. We can have as many measures as we want. We can have as many legal prescripts as we want, but in order for all of that to be successful, there needs to be proper coordination, there needs to be communication, and it needs to be a collaborative approach. And as Port Health, we are part of a lot of the coordination and response structures that are responsible or that deal with COVID aspects. And I've just named a few there. The National Joint Operations Center, we know that it's more of them, that the center that focuses on the response activities of the country as a whole. And also in the provincial JOCs, we're also part of the outbreak response team, both at a district level, at a provincial level, and also in the MNOT, which is the IMT now. And then also we are also part of the BMA border structures, where we sit with border stakeholders. And we're also part of the National Transport Facilitation Committee, where we sit together with the Civil Aviation Authority and the Department of Transport, and we coordinate on the response activities within the airports. And then we also have port-specific stakeholder forums. So each port of entry has its own forum where they sit and they then discuss their response activities within the port of entry. And I just put this quote from the president, one of the speeches from the president, which talks to, I think, the coordination and the communication and us cooperating, because it won't take one department to fight this. It's a collaborative approach, and we need to be working together in our different areas to do that. And basically just says, now is the time when we must intensify our efforts and deepen our cooperation. And my last slide, Dr. Bokhatso also already touched on this. These are the assessments, or these are the capacities that need to be in place in ports of entry to deal with public health emergencies. And COVID has provided us an opportunity to actually test whether the system is working. And from that, there are lessons learned that we have already picked up, and it's going to be assisting us in strengthening and ensuring that we are even better prepared to deal with the next pandemic, because we do not know when it's going to be coming. Thank you very much, facilitator.
Thank you very much for that significantly detailed presentation, and sharing your expertise and experience and guidance from the Port Health Services at the Department of Health. And that was Ms. Pam Masilela, covering traveling through ports of entry, ports health issues. And at this point, I need to just thank all of our presenters, but remind all of our attendees, we will be circulating what is called a red cap survey, and we want your opinions on our webinars, as well as other topics that you want the webinar series to cover, particularly the COVID-19 webinar series from an occupational health and safety point of view. So I'm going to post that link to the red cap I'm just going to click send, and the link is in the chat box for those who wants to also contribute additional topics that you may want us to cover in our webinar series. And I've just posted it on the chat box. What you could do is take a screenshot or just quickly copy out of the chat box the link. It will also be circulated via email. We will also circulate via email all the links to the presentation and the video recording of this webinar, and particularly for those who, we didn't complete all of the slides, for example, of some of our presenters, but there's very useful information contained in there. And a reminder, visit our website. Our website is zero rated, meaning none of the mobile service providers, the cell phone service providers, and an internet service provider charges you when you go to our website. And there's lots of useful information and resources there from a COVID-19 and occupational health and safety point of view. That was also posted in the slides, and I will put the slides on now once we close this. For our presenters and panelists, we have a few unanswered questions there, and I'm going to encourage Dr. De Vrij, Dr. Bagatsu, Pam, as well as Tsifiwa, just to have a quick look there at the unanswered questions there in the Q&A box. We hope to keep it open, say, for another 5 or 10 minutes or so. We would like to end the webinar officially by closing it down with 0 questions unanswered. We'd appreciate your assistance just in sorting that out. And so at this point, I say thank you very much to Dr. Albie De Vrij, a travel doctor, particularly dealing with those people for work purposes who have to travel, especially between countries, and may be exposed to occupational diseases due to traveling, who dealt with business travel during the COVID-19 pandemic. What is the way forward, and how do we get there? And then Dr. Lesego Bagatsu, thank you very much. She had such a lot to share with us, and unfortunately we had limited time. The Senior Aviation Manager at the South African Aviation Authority, who dealt with COVID-19 aviation industry preparedness. Opening airports and borders for international travel was her topic. And then on the topic of travel and tourism protocols, Mr. Tsifiwa Tsivengwa, the CEO of Tourism Business South Africa, and then finally Ms. Pam Masilela, on behalf of the Ports Health Services of the Department of Health, a partner government body of the NHLS and the NIH. She dealt with the traveling through ports of entry, port health issues. And on that point, I'm going to then finally display the slides again to give you certain critical information and to give our presenters and panelists a chances to clear those questions in the Q&A box. And please note, I have put the REDCap link for the post-webinar survey in the chat box. I will do so quickly again for those who, whoops, no, it's not there. 1 second. And I will repost it there for you to get the link for the REDCap. Thank you very much, everybody, for joining us today and for contributing your questions, and particularly our presenters. But least but not last, or last but not least, if I can get that right, there were our panelists from the occupational medicine section within the NIH, and that's Dr. Nompumelelo Ndaba, and she did quite a lot of work to put this webinar together and leading her team in doing so. And then there was Dr. Odette Volmink, Dr. Edward Sepirwa, Dr. Hlonipile Maso, and then, although not promoted, I think, yes, maybe Dr. Masvita Mberi, who also answered and dealt with questions in the Q&A box. Thank you very much. So at this point, I'm just quickly going to share with you again our slides to give you certain critical information in order for you to be able to access our resources on our website, which is zero rated, as well as the Twitter platform and our YouTube channel, where all of the videos for our webinars are available for you to view. So thank you very much, everybody, for joining us today. See you in our next webinar. We will be sending out the invitation to register soon.
you.